Greetings everyone, today I am giving introduction on inequity in healthcare delivery. First of all, let me define some terminologies. Health inequalities is defined as differences in health status or in the distribution of health determinants between different population groups. For example, differences in mobility between elderly people and younger populations or differences in mortality rates between people from different social classes. On the other hand, health inequity is defined as differences in health status or in the distribution of health resources between different population groups, arising from the social conditions in which people are born, grow, live, work and age. Health inequities are unfair and could be reduced by the right mix of government policies. Whereas for health disparities, it is the differences in health outcomes among groups of people. Next, I will talk about overview of health inequity. The concepts of health inequity and health disparity are inseparable in their practical implementation. Policies and practices aimed at promoting the goal of health equity will not immediately eliminate all health disparities, but they will provide a foundation for moving closer to that goal. To achieve health equity, avoidable health inequities and health disparities must be eliminated, and this requires short and long-term actions. These actions include attention to the root causes of health inequities and health disparities, specifically health determinants, a principal focus of Healthy People 2020. Particular attention to groups that have experienced major obstacles to health associated with socioeconomic disadvantages and historical and contemporary injustices. Promotion of equal opportunities for all people to be healthy and to seek the highest level of health possible. Distribution of socioeconomic resources needed to be healthy in a manner that progressively reduces health disparities and improves health for all. Continuous efforts to maintain a desired state of equity after avoidable health inequities and health disparities are eliminated. There is ample evidence that social factors, including education, employment status, income level, gender and ethnicity have a marked influence on how healthy a person is. In all countries, whether low, middle or high income, there are wide disparities in the health status of different social groups. The lower an individual's socioeconomic position, the higher their risk of poor health. The ways in which the health system is designed and administered may have important implications for the extent to which different populations are able to access, navigate, and utilize health services and, ultimately, on health disparities between groups. 3 dimensions of equity in healthcare have been identified in the literature: availability of services, accessibility of services, and acceptability of services. In addition, health literacy and cultural competency have emerged as key components underlying the availability, accessibility, and acceptability of the health system. This diagram shows the framework for conceptualizing equity in healthcare. Availability, accessibility, and acceptability are represented by the 3 overlapping circles in the diagram, with equity in healthcare existing within the center of the 3 circles. The health system itself operates within a much larger context. The items outside of the large circle, which means outside of the health system, represent several social categories, all of which compound and intersect at multiple levels to affect an individual's ability to identify and access services, as well as navigate the system. For example, individuals with limited knowledge of the national and English languages with low incomes may experience substantial difficulties in accessing and utilizing health services. They may be unable to afford to pay for public transit to attend their appointments, or they may be unable to understand and enact the health advice they receive. When programs or services are not available, accessible, or acceptable to all Malaysians, certain groups will experience difficulties in obtaining needed care, receive less care or a lower standard of care, experience different treatment by healthcare providers, or receive treatment that does not adequately meet their needs. There are many consequences of health inequities. Every day 21,000 children die before their 5th birthday. They die of pneumonia, malaria, diarrhea and other diseases. Children from rural and poorer households remain disproportionately affected. Children from the poorest 20% of households are nearly twice as likely to die before their 5th birthday as children in the richest 20%. Maternal mortality is a health indicator that shows the wide gaps between rich and poor, both between and within countries. Developing countries account for 99% of annual maternal deaths in the world. Women in Afghanistan have a lifetime risk of maternal death of 1 in 11, while a woman in Ireland has a risk of 1 in 17,800. Around 95% of TB deaths are in the developing world. These deaths affect mainly young adults in their most productive years. Contracting the disease makes it even harder for these adults to improve their personal economic condition and that of their families. About 80% of non-communicable diseases are in low and middle-income countries. In low-resource settings, healthcare costs for non-communicable diseases can quickly drain household resources, driving families into poverty. The exorbitant costs of NCDs are forcing 100 million people into poverty annually, stifling development. Besides that, healthcare inequities result in life expectancy varies by 36 years between countries. In low-income countries, the average life expectancy is 57, while in high-income countries, it is 80. A child born in Malawi can expect to live for 47 years while a child born in Japan can expect to live 83 years. Health inequities also can occur within countries. For example, in the United States of America, African Americans represent only 12% of the population but account for almost half of all new HIV infections. There is no biological or genetic reason for these alarming differences in health. In London, men's life expectancy ranges from 71 years in Tottenham Green Ward to 88 years in Queensgate, a difference of 17 years. According to the findings of the London Health Observatory, when travelling east from Westminster, each tube stop represents nearly 1 year of life expectancy lost. Health inequities have a significant financial cost to societies. The European Parliament has estimated that losses linked to health inequities cost around 1.4% of gross domestic product within the European Union, a figure almost as high as the EU's defence spending. This arises from losses in productivity and tax payments, and from higher welfare payments and healthcare costs. Over 800 million people in the world live in slum conditions, representing about 1/3 of the world's urban population. The likelihood of meeting the health-related Millennium Development Goals is lowered by poor health service delivery to hard-to-reach populations such as these. That's all for my presentation, thank you.